Sure.
Okay. Welcome, everybody. We're going to start off our session with Diane Jacobs, as you were hearing us chat a little bit about the tech setup here on how this is going to work, because it is a little bit different than webinars that we've done in the past, where there tends to be a presentation and slides. Instead, it's just going to be Diane and I on screen, and we invite everybody to ask their questions. Well, type in their questions. If you want to speak, like if you want to be able to turn on your mic to ask your question or share a comment, we can make that happen too. You just need to let me know in the chat. And tonight's session will be 45 minutes. We'll see how things go. We'll see how many questions there are for Diane about DNM. And it's a little bit of go with the flow. So we want everybody to participate. So feel free to put in your questions into the Q&A or the chat. And we'll come around to hopefully all the questions tonight. There were some questions that were submitted ahead of time, so that's where we're going to start. But before we jump into those questions, Diane, I'm just going to have you introduce yourself, the work that you've done, the history of DNM, how you got into it. Give us a little rundown.
Okay, like 5 minutes or less. There's really not a whole lot to it. Okay, so the history of I'd already been a physio for like 30 years, and I was plugging along, and I liked manual therapy. I was doing it, and I was not on the internet yet. Okay, I think this is a pivotal thing. Anyway, I finally got on there like around the year 2000, and also that was when I took a David Butler class. And so and his book, The Sensitive Nervous System, is the very first thing ever that I bought online. And I felt like such a grown-up buying a book online. And it was his book. Anyway, so my world got tilted and reversed. And so I had to think about nervous system. And up until then, like there's this whole thing about what is propositional knowledge and what is procedural knowledge. And this is John Vervaeke, right in your hometown there, Toronto. I really like his stuff. And I've been, inhaling all of his videos and everything. Anyway, but this little piece about all these different kinds of knowledge, and it does relate completely to, different parts of the brain and what they're good for, supposedly. So anyway, what is manual therapy? I mean, it's just like, it's procedure. That's all it is. It's procedures that got propositions attached to them. And the propositions that were attached to the procedures were what helped it be conveyed, from one generation to the next. But, I was able to finally access information that was of a more scientific kind, that was all about disputing and disproving these propositions. So basically manual therapy has nothing going for it if you look at it propositionally. There isn't any specific effect from it that anyone has ever elucidated or extracted. It's an art more than it's not a science at all. It's an art. So anyway, let's just strip all the propositions away and see what we've got left. What we've got left is a nervous system, and we've got actually two nervous systems. One is in a person coming to see you, and the other one is in you. And somehow you have to figure out how to get those two nervous systems to talk to each other, not just through verbally or, being a presence in the same room as them, but you have to figure out how to be connected to them kinesthetically somehow. If you're doing manual therapy, it's a contact thing. So, but you have to think, okay, it's two nervous systems connecting. So that requires thinking on another kind of level altogether. First of all, just subtracting all the tissue-based ideas, because they don't really fit. They just don't fit with this kind of person-to-person interaction that has to go on. So I thought, okay, nervous system, well, what do we have left? So after you take away all the mesodermal derivative of the body, which is almost the whole body, 98% of it is mesodermal derivative. It's like, you know, your muscles and your tendons and your this and your that. It's, you got the nervous system left over, and that's only 2% of the whole body. But man, it's huge. I mean, it's like very powerful, right? It's like 2% of your body runs the whole body. It's amazing to me still, you know, at this advanced stage. And to think that this 2% of your body is like, that's your brain, your spinal cord, and all your 72 kilometers of peripheral nerve. And that's what we're working with right there. And the rest of the stuff doesn't care if we exist or not. It really has no opinion on anything. The mesodermal derivative doesn't have any opinion. It can't feel you. It can't make any noise. It can't signal. Except chemically, it can a little bit or whatever. But the nervous system is constantly talking to itself at 400 kilometers per hour. And in order to do that, it requires 25% of all your oxygen and glucose that you take in. So this little tiny piece of your body, 2%, has to have 25% of all your energy in order to do its job, which is just to look after everything else that is there. That's, you know, instantiates you as an individual on the planet walking around. So to me, this is like, still looking back on it, I think, oh, wow, I was a manual therapist, and that's what I did for a living, because it's kind of awesome, actually. I mean, not DNM, no, just the fact that it has persisted as a behavior of humans up to this point in time is amazing, because it's persisted ever since. Going back, you know, into evolution, how far back does that go? It goes all the way back to primates. It goes all the way back before primates, probably. And here we are, we're still doing it, you know, and we're still receiving benefit from it, and we're still enjoying doing it. And for me, it was a calling. I mean, I just had to go do that. That was what I wanted to do with my personal existence. And so I ended up doing it for a long, long time. And finally, it made sense to me. So I got pretty excited about that. And for the last 20 years, I've been pursuing that kind of as an attempt to make a new set of propositions to go with the procedure of working on somebody else's physicality and trying to help them get rid of pain, you know, that kind of stuff.
Well, that was a great way to kick off the webinar.
Was
Yeah, it was fantastic.
Oh, all right. Next question.
That was the question to introduce yourself. But you did answer one of the first questions that we received prior to the webinar, which is, what is DNM? Is this a modality or type of manual therapy that trumps other modalities?
No, it's not. All kinds of manual therapies by any name, a rose by any other name would smell as sweet. And, you know, I mean, everybody with their chosen way of doing manual therapy, or their thing they call it, or whatever, they're gonna get, you know, the same amount of results as anybody else is, including this. It's not anything fancy. It's just that I wanted to make it clear in my own mind what was going on for me, and hopefully for other people that had questions, because I asked a lot of questions and I got a lot of answers. Part of the thing about hooking up with the internet finally at my advanced age, in the year 2000, was that I could join a community of other people that were skeptical and wanted to, you know, really wanted to understand things at a really deep level, and, you know, coherent level, and consistent with all the other science out there. So that's where I ended up. I got lucky, actually. Combination of maturity plus experience plus questioning plus, nah, that doesn't sound right. No, we're not going to believe that anymore. That's a piece of crap, you know, kind of thing, kind of attitude. And trying to get to the bottom of a mystery. And, you know, it's still a big mystery, but at least the mystery's more clear. We didn't clear up the mystery, but we made the mystery a little more clear, I think.
Just unmute myself there. There's a couple of like practical questions. So I'm going to just ask those. What was the name of the book that you read? I think you mentioned it in your introduction. You talked about a book that you read.
Oh, yeah. Sensitive Nervous System.
The Sensitive Nervous System?
By David Butler.
Okay.
A physio in Australia. I don't know if he still teaches or not. He's with a thing called the NOI group, the NOI group, Neuro-Orthopedic group, something like that. Anyway, he wanted to blend orthopedic manual therapy and physiotherapy into neuro. He was trying to bring those two worlds together back in the day, and they still are, his group.
And I just dropped their website into the chat. So if anybody wants to check it out, they can do that.
Yeah, I'm sure it's still for sale. It's also on Amazon, if anyone is looking for that book, Sensitive Nervous System by David Butler.
And somebody had a follow-up question about DNM being a mechanism, not a modality.
No, it's not a mechanism. It's not modality. It's not a mechanism. It's just a way of looking at manual therapy. And you can kind of do it any way you like. It's still, to me, it's like a big stretchy container that contains all the manual therapies because they're all in there. Dermo is skin. You can't do any manual therapy without contacting skin first. So that's why dermo is in front. And then neuro is, yeah, there's the rest of the nervous system in there. Whew, and it's picking up on what you're doing. Ooh, and it's paying attention. And oh, there's a person in there too that is in pain. Okay, let's see if we can smooth this out a little more. Let's change nociception to yesiception and see where we get. That's kind of the gist of it. Because modulation means change, hopefully in some direction that the person wants.
Okay, this is a good question.
Okay.
Maybe a lot of people have run into this, but the question is, I'm a massage therapist and a certified lymphatic therapist. How do you get people to buy into the gentleness of the treatment when so many clients seem to want you to beat their muscles into submission?
Oh gosh. When you are trying to go after muscle, you're missing a whole layer of that human that's right on the outside, which is the skin layer. And the skin layer is actually a big organ. It's quite thick and it has tons and tons of neurology in it. And so you have to think a little more superficially, maybe, like, and also you could point out, if you're this person who's confronted with a person that thinks you have to dig into muscle, you have to ask yourself, is it that person really wanting me to dig into muscle, or is it me thinking that I should dig into muscle because somebody taught me that a long time ago, or something like that. Like, you check your priors every time. The muscle won't care whether you dig into it or not, but the skin sure will, and the nervous system sure will. And maybe you want to save your hands and keep them going a lot longer than if you use them up too quick, you doing deep stuff on people. It's not necessary. Every nerve in the, coming out of the spinal cord ends up in the skin somewhere, or at least a branch of it will. And so there's no need to really, if you think neurodynamically, all you have to do is move the nerve and then you're fine. And things change. If they're ready to change and the person's ready to have it change, then it will change probably. No guarantees, but you end up with more hits than misses after a while, pain-wise. So you have to convince yourself first, and then you can convince your people later.
Another practical question. I was wondering how you record your observations or tissue observations regarding applying DNM.
Oh, I Sorry, can you just say that a different way? Because I'm not understanding the question. Does that person mean charting or?
Yeah, I think so.
Okay, well, you can just, I used to just write down what nerve I addressed or, hoped that I had addressed. That's how I did that. So I would name the nerve and I would, or name the part of the body and I'd put down soft tissue work or something like that.
What is your opinion on neurodynamics by Michael Shacklock for neuromobilization?
I love it. It's fine. It's good. It's good. I like it.
Okay. We have a few questions about conditions. So there's some
Okay.
condition-specific questions.
All right.
There was one sent in beforehand. Actually, I think there's a duplicate. Okay. So one person asked about DNM for CRPS, more specifically of the upper extremity. Have you tried it with this patient population and had any success?
Yes. Yes and yes. And I didn't treat very many people with that. There are people that ended up coming to me for that were few, far between, but yeah, it helped. But you have to go really like 10 times lighter and 10 times slower than with someone without CRPS. It's like, you just have to be a lot more careful because they're a lot more sensitive. Also, there's a video online where you can see it's oh god, what did they used to call it? What did they used to call CRPS? I forget. They called it, what was the old name for that? I can't remember. Anyway, so there's this society or something still called that, and this physio named Jonathan Fass he went online with these people and so did the patient that he treated. And so they were all talking together about his recovery, and his recovery was from a CRPS in the foot, I think. Well, it's quite a while ago. Anyway, but yeah, it got better. And DNM was mentioned by name in that video, which I thought was really kind. Anyway, so yeah, it works. And what I've treated a kid with an ankle issue who she fractured her talus or something when she was a very young child. She was 7 or 8 or something like that when it happened, sprained ankle, but it was also a crack in the talus. And then after that, she had CRPS. And I saw her when she was about 15 and she was still having issues with it. It would swell up and turn blue and then it would go down, and she'd have to have a brace on for a little while and it would go back down. And so I treated her a few times and we worked out that she was a sports kid too. Like she was running around and doing track and field and I don't know, gymnastics and things. So clearly her ankle could take it could take the rough and tumble of her life, but where it would swell up would be when at the end of the practice, when they had to put their stuff away. That's when it would swell up and she couldn't do that. And so thinking about that, I thought, okay, right. Okay, so when she's in that situation, she's not doing what she loves. She's doing something she doesn't love and something somebody tells her to do. So I proposed that maybe she take a moment before putting the stuff away and talk to her teacher and say, okay, I can do this, but I can't do that because it's just a little too much for my ankle, and be assertive with her, her physicality, because she does have this thing that's a condition that kind of came and bothered her and then went away again. But then she'd have to come in and get treated, So she didn't want to have to do that her whole life. So I said, take care of your ankle, make your boundary and make sure everybody knows it's there and that's where it is. And somebody else maybe can carry your thing back to the storage room, whatever. So anyway, that's after that, I never saw her again. So I guess maybe it helped. Anyway, yes, CRPS can be treated with DNM as long as you're very,
light and very slow. Wonderful. Thank you for sharing. A few other condition specific. There was 2 around trigger points and sorry. Is pin and compress effective for trigger points in posture muscles / non-sensitive muscles?
Okay, that's a kind of manual therapy that I don't do, so I don't know.
Okay.
DNM is useful for sore spots. We'll call them that. Sore spots, getting rid of sore spots, getting rid of the parts of the body that hurt on movement, or with certain kinds of forces. Usually some kind of movement problem. So yeah, it's good for that. But I don't know about, I mean, I don't care about muscles particularly much at all at this point in time, or for the last 20 years. So the postural or the, it doesn't matter. They're all the same to me now. Muscles. I don't have any propositions that go with muscles.
Okay. This one says, thank you for all your wonderful ideas, Diane. I'm a huge fan of your techniques, OTCHT here. Could you please share any tips on treating trigger fingers with DNM?
Trigger fingers. Oh. Trigger fingers. No, I don't have any tips for that. Sorry. I don't.
Okay. How about a frozen shoulder? That was the next question.
I've had one of those. Oh,
personally?
Yeah. Yes.
Oh.
Yes, I have had one of those. It's not fun. Mine lasted about 3 weeks. And I took myself off to see a friend who's a physio. I asked her if she would help me, and she said, sure. And so I said, okay, but I have to be the boss of you, okay? And she said, yeah. And I picked her because she was just the perfect physio for me, because she was also a doula, okay? Now, she knew about people being in pain, and she knew about women being in pain. So I figured, okay, this woman will handle my spicy language, and she won't mind that I'm in pain, because that's, when you're having a baby, you're pretty much in pain, I should think. And I've never had one. I've avoided that one. But now, anyway, so I had her treat what I thought was the problem, a musculocutaneous neural entrapment, where it goes through coracobrachialis. That poor nerve in there was trashed on me for the previous 20 years, and then decided to freeze up and make pain. Anyway, the woman that I went to see, she was great. She did exactly what I wanted her to do for exactly how long I wanted her to do it for. I took total locus of control over my painful shoulder. Anyway, it mopped up. As soon as after the first treatment, my range of movement went from about like there. Can you see me? Oh yeah, that's as high as it would go. And then after she treated me, it went up to there. So that was good. So I put my hand up on something that was about that tall, and then I moved. I did a bunch of idiomotor moving around, and just moving all over the place. And it felt so good to be able to move with my arm up that far, moving from central to peripheral rather than peripheral to central, the way arms normally work. And she laughed at me and she said, Diane, you look like you're having a baby. I said, it feels like I'm having a baby through my shoulder. Anyway, it totally diminished and went away. It took about another 2 weeks to go away, but I only ever saw her that one time, I think, maybe twice. Maybe it was 2 times. And all the range came back. And not only that, but I ended up with more range in my frozen shoulder than I'd had in internal rotation for the previous 20 years. So now I've got pretty good internal rotation on both arms. And before I was stuck there, wouldn't internally rotate any further. That was 20 years of this amount of range. And then now I've got, I call it flow range. It's good enough.
Wonderful. Thank you for sharing. There's a few more questions, and are you good to keep going for another few minutes? Yeah. Okay, ask away.
Yep.
Okay. When you do one of the techniques like lifting the skin, compression, or distraction, how long do you hold for? Is the patient or the therapist supposed to feel a release?
Okay, so here's where we get into the nebulosity of it all and the subjectivity of it all. And, you know, I would say lateral skin stretch is the only thing that I do with the skin specifically. And you can do that in so many different ways. You can twist it and you can lift it and you can, you know, you can be really inventive in the area of what do you do with the actual skin. As long as you're not poking down into it, you're fine. Okay. Then lateral skin stretch is where you will get all of the Ruffini endings, which are the ones that are sensitive to lateral skin stretch. Not only that, but the lovely little Ruffinis, they're type 2 slow adapting. So they will stay turned on the whole time you've got the skin stretched. And what are they? They are non-nociceptive. They are very fast. They're faster than the nociceptive specific kinds of fibers are. And they so they stay turned on, and so they'll get to the brain faster because they're bigger, and they will help the brain turn, you know, from nociception over toward being interested in the innocuousness or the yesiceptive aspect of Ruffini's and what they can send upstairs. So it's kind of like just finding yourself diluting the whole nociceptive aspect of people who have sore spots and that kind of thing. You can literally, you know, pull skin away from a sore spot and it won't be sore anymore. It just won't be. So anyway, that's kind of a cool thing. And then how long does it take? It takes as long as it takes. So no fewer than 2 minutes, because it really takes about 2 minutes to even get the whole process started. Like you have to wait for it to search, you know, to get around through all the loops that are in there and feedback loops and everything else. And then you can just hang out there for as long as you want to until you stop feeling any change, right? You'll feel all kinds of stuff going on inside there, you know, after a while, after you got used to doing it. And there's this wonderful capacity the nervous system has called temporal summation and also spatial summation. Spatial summation is, it's kind of like everything that's in a neighborhood that you're touching, it's going to fire no matter what kind of neuron it is. And what you want to do is not trigger any nociceptive neurons. So I'm a big advocate of don't hurt people. They're already in pain. Don't hurt them more. Just, you know, try to distract their, not them. You want them to pay attention, but you want their, you know, whatever's going on inside their brain that's busy, you know, giving them a pain experience. You want that to slowly to ebb and disappear and stop hurting them. So take, you know, sometimes it, you know, 2 minutes to 10 minutes, somewhere in there per nerve.
Someone's asking about where else to learn from you because it's a new technique to them or a new modality. Is there a place to learn the general principles for this?
Well, there are classes that other people teach now. I'm completely out of the teaching kind of arena because I'm retired and I like it that way. So there are classes all around. If you go to the website, the people who do teaching are listed there. But also if you just go on Facebook, there's a dermoneuromodulating group. And if you ask your question and what part of the world you're from, you can find out if there's a teacher in your neighborhood or whatever, or in your vicinity anywhere or in your country. And if not, maybe you can travel, and go somewhere where you can get a class in. There are teachers in England. There are teachers in, I think there's at least one in Italy. There's maybe a couple. There's several in the US, Australia, Taiwan. I think there were a couple guys there that asked if it would be okay to teach it. I said yes, please, by all means. So yeah.
And you have a book and you have a course.
Yeah, I have a book, and the course is on Embodia with you.
Yep. And your book, I guess what I'll do is I'll put together just a list of the resources afterwards and send those out. So your book, the DNM website, your course, those sound like the 3 resources.
Yeah.
Great.
Okay. And other people that can teach the actual skill sets, and they've all developed it their own way too. So there isn't just one way to do it. There's all kinds of different ways, but you'll learn the principles from these guys and women and guys.
Okay, so more questions. Does the lack of interest in muscles mean that's just not your focus? Or do you reject the underlying logic of people trying to work with Golgi tendon reflex or reciprocal inhibition?
My question I would ask is, how do you separate them from the rest of the body? Like, how do you, like, going after something like a gold, how do you get to it? Because there's this big skin organ in the way. I mean, like, the skin organ is covering up your muscle that you think you're going after. It's like, no, the skin's going to have an opinion. The nervous system that's in the skin is going to have an opinion, and it's going to have a reaction long before you ever get to muscle. Muscle doesn't care about how you dig in on it. It doesn't care. It doesn't have that kind of capacity. Neurons do, and neurons are in the skin and right at the surface, right where the world is. So, I mean, that's what they're there for, is to register what's coming in to their organism from the world, from the environment, and you are part of their environment. So muscle is, it's excitable, but not by anything coming to it from outside of the body. It's excitable only by neurons that go into it from the motor cells that are, in the spinal cord. That they don't care about anything else in the whole wide world. They just care about being excited or not excited by these neurons. So muscles don't even, in my brain, I mean, I deleted muscles out of my brain a long time ago because I can't affect them directly, So I give up. I'm not going to worry about them anymore. I even forgot most of the names of them. It's like, I don't care. So I care about the person and what they're feeling. I really care about that a lot. And I want to not be a source of noxious input to them. I really don't. And I really don't want to be a nocebo to them either. So I just want to have their nociception fade away and replaced with yesiception. And the muscles will take care of themselves because the brain inhibits the spinal cord. That's its job, is to inhibit the spinal cord so the spinal cord can't take over and, make the person not be able to have voluntary movement the way they want. There's all kinds of ways to work with the nervous system once you understand how it works. And when you understand how it works, then you can work with it. And you can forget about muscles. They don't matter. Lots of people are born without some of them. And they do fine. They just, they do just perfectly well in the world. Anyway, I'm sorry, but that's how I feel about muscles.
Great answer. Do you think myofascial cupping techniques with only slight suction pulling the skin can work as well as DICEM, or do you think it has to be skin on skin to succeed?
Oh, no. You can do all kinds of stuff. You're still working with the skin organ, really, like, hey, if it helps that person, that's fine. It's the propositions that I'm concerned about, okay, not the procedures. As long as they don't hurt the patients, I don't care what they are or what they used to be called. But if you've got a cup that you want to use and the person likes the way it feels, hey.
Okay. All right. I think that answers those questions. There's some in the Q&A. Can you teach a patient to do certain techniques on their own?
Oh, yeah. I used to hand out pieces of DICEM to people because it makes it so much easier, right? Because DICEM has such good skin grippage, and you can really pull good with the DICEM. And it doesn't take as much effort, and you don't have to press in as much to get a good grip and all this stuff. DICEM is like a huge labor saver. And yes, and I used to give it to people and say, take home, here, you can do this to yourself. You don't have to come back unless you really need me to help you with something. But if it flares up again or it bugs you, try this, and maybe you can take care of it from now on. So I had all kinds of tricks that I would teach.
I don't believe you're a pelvic floor therapist. Is that right, Dan? This person is asking about DNM.
I've not done any pelvic floor rehab stuff or any of the specialization or any of that stuff, no. But I do treat pelvic floors. I treat the externality of the pelvic floor. I treat the nerves that go there. And there's the perineal nerve is my favorite nerve to treat in the pelvic floor because it's the one that's in the skin, and it's easy enough to treat and gets rid of a lot of pelvic floor pain with just a simple, non-invasive strategy.
Can you elaborate a little bit or describe the technique?
Sure. Okay, it's one that I invented. Okay. You live long enough and you just run out of ideas that other people taught you, and you just have to start inventing your own ideas. So a guy came to me one time who he was in quite dire straits. He'd 10 years earlier or something, he'd been an airplane mechanic working in I think he was in the forces. Anyway, he was underneath a plane and he had one foot up against the plane. He was pulling hard on something and he pulled so hard that he prolapsed his rectum. Okay. So like this guy had nothing but trouble from this prolapsed rectum. First of all, he needed all these surgeries and they'd fix him up, and then he'd get a fissure, and then he'd have an infection, and then it was like endless looping of painful, horrible medicalization of this horrible problem that he had that was a surgical problem. So anyway, he ended up with chronic pelvic floor pain to the extent that 10 years later, he was walking with a quad cane and he couldn't really sit. I asked him how it felt, and he said, well, every time I sit and every time I stand up, he said, it's like this lightning bolt this big that goes up into the area behind my testicles. He said that's what he called it. I said, oh, your pelvic floor. And he said, oh, is that what it's called? Yeah, okay, pelvic floor. And he said, it hurts when it goes in, it hurts when it comes out, and that's how it is, and that happens 50 times a day. Oh, okay. So the guy was in misery. He was on 800 pills a month or whatever, and and his wife was really good. She looked after him really well and everything, but he couldn't do anything. He just had this pain problem. So I tried out what I already knew how to do, which didn't work with him at all. He was way too sensitive. He was in way too much pain. And so I thought, okay, well, maybe you'd be more comfortable on your side. So he turned on his side, curled his legs up, and he was more comfortable that way. And so I wrapped my hand around basically he still had his underwear on and everything. Just moved the skin up away from midline. That's all he did, was just hand on the butt cheek kind of thing, and just pulled skin away from midline. That's all I did. Swear. I swear. Anyway, and it totally relaxed one half of his pelvic floor. So boom, he flipped around and did the same thing on the other side. And then he walked out with his quad came over his arm, and he went back to sailing. So he did okay, you know. And he came back one more time and he said, I want you to teach my wife how to do that thing that you did, just in case it ever comes back. Because the guy had been in agony for 10 years. So I taught his wife how to do this thing, and she said, okay. And away they went. And last I heard, he was doing okay. So that was my contribution to pelvic health.
That's quite significant.
I hope so. I mean,
Yeah.
I hope it makes the world a better place for people with pelvic health problems. Pain, anyway.
Do you have any thoughts on Charcot-Marie tooth disease?
No, I don't know what that is even. But I might have known once upon a time. But
If anybody wants to clarify.
is that a painful condition?
Says it's an inherited group of disorders that cause nerve damage.
Oh,
Damage is mostly in the arms and legs, peripheral nerves.
huh. You know, with DNM, I mean, with manual therapy, we're not really treating conditions. Okay, we're treating pain. We're not treating conditions. If you're treating conditions, you're kind of misrepresenting manual therapy. Maybe it's, you know, until there's actually some sort of basis that when you do this XYZ to this kind of condition, then it works every time or most of the time, then you could say, oh, I treat that condition. But I just stopped using labels completely. Like, I just don't, people come in with their, you know, their MRI or their thing that their doctor gave them, you know, they're degenerate. I just don't worry about it at all. It's like, nope, not going to go there and label that. And where do you hurt? I want to know that right off the bat. Tell me where you hurt. Then I'll figure out what nerve is hooked up in that neighborhood. And then we'll treat that nerve and see if it helps. I don't know. Maybe it will. Let's, you know, if you want, we can try that and find out and see what happens. You know, I promise I won't hurt you. You have to make that clear from the very start, that you're not going to hurt them and that they're in control. And if they tell you, no, that hurts, then you stop and you say, okay, well, man, let's try it a different way. You know, you just give them the option of being the boss of this interaction in the moment. I mean, you're the person that knows the stuff, but they're the person that needs the help. And it behooves you to try to help them feel better walking out than when they walked in, you know.
So there's a couple of questions about whether you've seen patients where DNM just didn't seem to help them.
Oh yeah, for sure. I mean, there's lots of different kinds of, quote, pain problems that are beyond the purview of manual therapy to help. And that's just a fact of life. So there's this really weird condition, weird to me anyway, because I haven't seen it very often, maybe twice in my whole life, called hyperpathia. Or it's also called wind-up pain. And that, you don't want to do manual therapy with that because it just makes them worse, makes the pain worse. And it's some kind of weird nervous system issue where Simon Beggs explained this one time. So it's some kind of electron that's on some sort of like lysergic neuron or something like that, or in the synapse in there. So there's this, it's a positive electron instead of a negative electron. I mean, it's something really tiny. And it makes the glycinergic neuron excitable instead of inhibitory. Can you imagine? Anyway, so if that's the way they're born and that's what they got going on in their spinal cord, you don't want to be messing with that with manual therapy. It just makes them worse. And so yeah, I made somebody worse treating them, and they had hyperpathia, and I didn't pick up on it in time. And yeah, so after that, I was a lot more careful. But so that's a condition that you can actually aggravate with manual therapy. Another one, the famous one, fibromyalgia. You're not ever going to help fibromyalgia with hands-on work, except you'll help the person living inside that nervous system feel better for a while. But they're not going to get rid of their fibromyalgia with manual therapy. So what is manual therapy good for? It's really good for pain that is localized to one area of the body or one region. Okay, it doesn't spread. It's always in the same place. It changes with position or rest, so you know that it's a mechanical thing. And that can easily, that's just going to be some kind of neuritis issue. Okay, so mop that up, then it should be gone forever. But the other stuff, it'll always come back because it's more of a chemical problem, right? That makes sense?
Yes, thank you. Okay, well, we're going to wrap up soon. The questions are still coming in.
Okay, well, let's see if we can get a few more in.
Okay.
We've got what, 10 minutes more?
Yeah.
Okay.
When you have a patient who has scapular, shoulder, and elbow pain, where do you start? I assume proximally.
Well, ask the person about the pain. There's no protocol to any of this stuff, okay? Ask the person where they hurt the most. Why don't you start there?
And this is maybe a dumb follow-up, but do you start where they hurt the most?
I do.
Okay.
Yeah, I hone in on wherever the light is the brightest, start there. That's where, that's the part that's calling the loudest for help.
Hey, from Winsome, absolutely understand treating the conditions versus the patients. Met someone yesterday whose child has CMT type 3, 15-year-old, and he is very severe. They're in a wheelchair, can't feed or toilet themselves. I've known someone else for 35 years with a different variety of CMT. With a nervous system that's so damaged, I wondered what sort of effect DNM can have. I have MS, my nervous system isn't as damaged as those individuals. My body loves DNM type work, relieves spasticity, pain, etc.
What's CMT? I'm sorry.
Perhaps they can clarify in the chat.
I don't know. I don't know the condition off the top of my head. Is that charcoal? Is that charcoal Mary tooth?
Oh, maybe Marie tooth.
Okay. Well, you can't harm people by doing manual therapy except in that one instance where it's hyperpathia. But I don't know that it would do any actual help, but I don't know, because I never treated the conditions. I don't know.
Idiopathic neuropathy falls into the chemical sort of issue? Question mark.
Sorry, say that again.
Idiopathic neuropathy. Does it fall?
Idiopathic neuropathy. Okay, carry on.
Does it fall into the chemical sort of issue?
Oh, there's a million kinds of neuropathy, isn't there? So I don't know. I know that it helps with pain, but I don't know if it can help with neuropathy.
I think Diane treated cranial nerves. How can I learn about that? About treating cranial nerves?
Treating cranial nerves, the people to check out would be the people in San Jose. They used to, at least they used to teach about cranial nerves and how to treat those. The cranial nerves, I went and took their class because I was interested in what they had to offer. So any of the cranial nerves that are on the outside of the, like in the skin and all that stuff, you can easily treat those because you can get your hands on their face and pull their, their nerves around a little bit and twizzle their nerves. If they've got headaches, that kind of stuff. And, the eyes, the cranial nerves that are on the inside of the head, like the ones that run the eyes, there's a whole bunch of them that run the eyes. So you can teach eye exercises, and, you can pretty much just get a book out on cranial nerves and then you can just invent ways of treating them if that's what you're interested in doing. I was never interested in breaking it down into, do this thing for that nerve, or anything like that for the head. It was just try to get rid of the sore spots on the head and on the back of the neck here.
Okay, maybe this question was answered earlier. So if you missed any of the questions and answers, then you can go to the YouTube channel or to our YouTube channel, and we're going to leave the live stream of this up for 48 hours. So if you just happen to jump in late, I just see some questions that are repeats, so we won't answer them again.
Maggie, can I post it to my group?
Sure can.
Okay, and so the YouTube version is going to be up for just 48 hours. That's it?
Yeah, we can leave it longer if you'd like, and I can send you the link. I'll send you the link by email afterwards, Diane, so then you can just share it.
We'll see how
Does that work?
Yeah, thank you.
Okay. Do you have any final comments that you'd like to make, Diane, before we close out?
Oh, okay. Well, I had an epiphany recently about pain and trying to find a metaphor, that explains what it is. Anyway, I think this one might work. It's all your priors, all your your experiences in life and your memories and your, harms that have been done to you, or that like all your experiences is sort of like in a pre-mixed, cake mix in a box, those things you can buy, make a cake with. Okay, it's all mixed up in there and it's all refined, right? It's like all your memories and your dreams and your hopes and your failures and everything else is in there in this box. And then you add milk and egg, and that's like nociception and yesiception. Okay, so nociception, it doesn't matter which one is which. It's just all somatosensory input. And then, so you mix all that together and then you put it in the oven, and then the thermal regulation of your environment is going to be baking the cake. And then you bring the cake out and that's the pain. Okay, so all the ingredients are needed in order to make pain. All your everything, who you are as a human. And then extra nociception coming in from the outside world. And then, it gets baked and that's your pain experience. And then so along comes a therapist and tries to, help you eat up your cake and get rid of it. So pick me, I like cake. And so that was the thought I had. And the other thought was about manual therapy in general and how I really, really, part of what motivated me, and I'm telling you, I'm not that motivatable really in life. But what motivated me to do all this stuff for the last 20 years is just like, I really, really love manual therapy, and I really wanted it to make more sense. And I wanted it to get more respect in the world, because it doesn't get enough respect. It's this thing that we can do, that we're called to do. It's a calling, it's if it weren't a calling, there wouldn't be so many people doing it, is my take on the world. So I wanted to salvage what was good about it and kind of renovate it, like finding an old home somewhere that's all falling apart and taking it down to the bones, and then making a new house on the old very sturdy framework of the, the old house. Keeping the good hardwood and the good timbers and everything. So that's what I wanted. It was a project, right? I wanted to renovate manual therapy and bring it up to date so that it was consistent with everything else. And well, anyway, that was my goal in life, and now it's achieved.
I think that's a wonderful place to leave this Q&A.
I think so.
Thank you so much, Diane, for spending an
Maggie.
hour with us
Oh,
and answering all of the questions.
Oh, you're welcome.
We'll send out an email later with just some links to the resources, a link to the YouTube live stream, so you can watch it if you missed any parts of it or watch it again.
Thank you, Maggie.
You're welcome. Thanks, Diane. Have a good evening.
You too. Bye-bye.